रीड करो, ये क्वेश्चन है
Okay, babesiosis ना?
बेबिसियोसिस वाला।
Okay, babesiosis epidemiology, Babesia microti. Babesia microti exotis scapularis tick bite, Lyme disease, and HGA. HGA means human granulocytic anaplasmosis. Okay, human granulocytic anaplasmosis, exotis scapularis tick bite, Lyme disease, and human granulocytic anaplasmosis, northern United States. Okay, epidemiology. Then clinical manifestation: fever, fatigue, myalgia, headache, flu-like symptom. If severe, ARDS, congestive heart failure, DIC, splenic rupture, anemia, thrombocytopenia, increased bilirubin, or LDS and liver function test. Acha. Then the diagnosis: thin blood smear. Acha, just the thin blood smear. Intra-erythrocytic ring, Maltese cross sign. Maltese cross sign. Then treatment: atovaquone and azithromycin. Atovaquone plus azithromycin or quinine plus clindamycin if severe case. Okay. Babesiosis is a tick-borne protozoal illness endemic to northeastern United States. It is transmitted by Exodus scapularis tick approximately 48 to 72 hours after attachment. Because scapularis also transmit Borrelia burgdorferi, Lyme disease, and Anaplasma phagocytophilum. Human granulocytic anaplasmosis co-infection is fairly common. Tick prevalence is in July and August when tick population are at their highest. July and August peak prevalence. Infection is often asymptomatic or mild, but patients with immunocompromised age more than 50 or splenic are at higher risk of severe illness. Symptoms typically include the gradual onset of fatigue, malaise, weakness, chills, and fever. The organism multiplies in the red blood cell, so patient may develop anemia with sign of intravascular hemolysis, jaundice, dark urine, indirect hyperbilirubinemia, reticulocytosis. Reticulocytosis, elevation of aminotransfers, and lactate dehydrogenase. Thrombocytopenia is common and mild hepatosplenomegaly may occur. The diagnosis is made by identifying organism on peripheral blood smear, Maltese cross sign. Treatment includes 7 to 10 days of atovaquone plus azithromycin or quinine plus clindamycin for severe illness. Symptoms may take up to 3 months to fully resolve. Okay. Choice A. Rocky Mountain spotted fever, also transmitted by a tick bite. Symptoms often include fever, headache, myalgia, and prominent rash, macular or petechial that spread centripetally from periphery towards the center, and include palm and sore. Hemolytic anemia is uncommon. Acha. Then the Lyme disease. Lyme disease is also transmitted by Exodus scapularis. Early disease is usually characterized by erythema migrans, a punched out spreading rash, fever, myalgia, headache, and lymphadenopathy. Anemia with intravascular hemolysis is not a feature of this illness. Then choice D, ehrlichiosis. Ehrlichiosis is a tick-borne ameblioma americanum illness. Ameblioma americanum, tick-borne illness that cause non-specific symptom, fever, myalgia, headache, and leukopenia, thrombocytopenia. It primarily occurs in the southeastern, south central, and mild Atlantic United States rather than northeastern United States due to geographic distribution of transmitting tick. This patient with leukocytosis and sign of intravascular hemolysis is more likely to have babesiosis. Okay, then choice C. The diagnosis of dengue fever can be aided by using tourniquet test, which involve flattening of the blood pressure curve on the arm to a point halfway between diastolic and systolic pressure, and examining for petechia 5 minutes later. Dengue fever is often asymptomatic, but some patients develop fever and severe myalgia, headache, backbone fever. Leukopenia are not. Leukocytosis and thrombocytopenia are common. Intravascular hemolysis would be atypical. Acha. Then choice F. Choice F, acute viral hepatitis, usually characterized by fever, vomiting, jaundice, abdominal pain, and dramatic elevation in aminotransference more than 1,000. Okay, so aminotransference should be more than 1,000. Okay, education objective. Babesiosis is a tick-borne protozoal illness found primarily in the northeastern United States. Transmission occurs via Exodus scapularis, tick, and co-infection. Exodus scapularis tick and co-infection with other micro, Borrelia burgdorferi, Anaplasma phagocytophilum can occur. Some symptoms are often flu-like, fever, chills, and malaise. And laboratory study usually show anemia with sign of intravascular hemolysis, thrombocytopenia. Diagnosis is made primarily by identifying organism on peripheral blood smear, Maltese cross sign. Maltese cross. Okay. So we have to remember a few things. Northern United States, and then a flu-like symptom, we get intravascular hemolysis, thrombocytopenia, and Maltese cross sign on blood smear. Thin smear. We will have to do thin smear here. Thin blood smear. Okay.
रेट्रोफेरेंजियल स्पेस वाला पढ़ो.
Okay, retropharyngeal abscess. Epidemiology age 2 to 4 but can occur in any age group. Polymicrobial group is Streptococcus, Staphylococcus aureus, and respiratory anaerobe. Okay, Streptococcus, Staph aureus, and respiratory anaerobes. Polymicrobial age 2 to 4 at any age group. Acha. Then symptoms. Symptom fever, odynophagia, dysphagia, neck pain, drooling, muffled, hot potato voice, and trismus. Examination rectopharyngeal bulge, limited neck extension. Diagnosis lateral neck X-ray, increased pre-vertebral thickening, CT scan with contrast. Management airway protection, intravenous antibiotic, ampicillin, sulbactam, and clindamycin. Surgical drainage. Okay. This patient fever, odynophagia, dysphagia, neck pain with extension, muffled voice, and X-ray finding are concerning for retropharyngeal abscess. Retropharyngeal abscess is a soft tissue infection of the neck due to polymicrobial bacterial Streptococcus pyogenes, Staphylococcus aureus, and oral anaerobes infection of potential space between the pharynx and the vertebral fascia. Acha. It is most often preceded by upper respiratory infection, as in this case, but can also result from direct spread of local bacterial infection. Upper respiratory tract infection, as in this case, okay. Direct spread from local bacterial infection, pharyngitis, tonsillitis. Retropharyngeal abscess occur most commonly in children aged 2 to 4. The incidence decrease after age 4 due to retropharyngeal lymph node regression and fewer viral upper respiratory infection. On lateral neck X-ray, the prevertebral soft tissue space is normally narrower than the vertebral body. Widening of this prevertebral space is suggestive of retropharyngeal abscess. A CT scan with contrast confirms the diagnosis. Large retropharyngeal abscess can obstruct the airway and major vascular structure. Early diagnosis, appropriate airway management, prompt antimicrobial therapy, and surgical drainage for large abscess are essential to prevent obstructive complication. Okay. So they are saying lateral neck X-ray, pre-vertebral soft tissue normally narrower than the vertebral body. Okay. And widening of the perivertebral space suggestive of retropharyngeal abscess. We can also do the CT. In fact, CT is the confirmatory test. Confirm the diagnosis. CT scan with contrast. Okay. And large retropharyngeal abscess obstruct the airway, major vasculature. Early diagnosis, appropriate management, and antimicrobial therapy, surgical drainage for large abscess. Okay, if it's small abscess, then just the medical management. But for large abscess, surgical drainage. Then choice A, epiglottitis. Epiglottitis present with high fever, drooling, and stridor. Drooling and stridor. These things are main. Lateral X-ray show swollen epiglottis, thumb sign. Thumb sign is present in epiglottitis, which is not present in this child. Okay, choice B, meningitis present with fever, neck stiffness, pain, headache, and photophobia. Neck flexion is painful due to stretching of the inflamed meninges. Extension usually bring relief. This child has pain with extension, and the absence of headache and photophobia make meningitis unlikely. Muffled voice and X-ray change are also not typical of meningitis. Achha. Then the peritonsillar abscess. Peritonsillar abscess can also cause fever, muffled voice, short pain, and trismus. Significant tonsillar swelling can cause uvular deviation of the contralateral tonsillar pillar. This child has no tonsillar mass in uvular deviation. Then tracheitis is caused by bacterial superinfection of the trachea following upper respiratory tract infection and present with severe croup-like symptom. Tracheitis. Okay, croup-like symptom including fever, stridor. Neck X-ray show tracheal narrowing. This child has no stridor or tracheal narrowing on the X-ray. Educational objective: rectopharyngeal abscess in child present with fever, dysphagia, muffled voice, and pain with neck extension. Lateral neck soft tissue X-ray show widened prevertebral space. Okay, so if we get muffled voice, then rectopharyngeal abscess. And if we get drooling and stridor, then epiglottitis. And for tracheitis, they are also causing uh, stridor, but croup-like symptom. High fever, stridor. Okay, croup-like syndrome means high fever and stridor, but drooling is not there. We can differentiate tracheitis and epiglottitis. In epiglottitis, there is a drooling and stridor, but in tracheitis, there is
Hmm.
fever and stridor.
Hmm.
And rectopharyngeal, to the muffled voice. Croup, subglottic narrowing of the trachea.
Hmm.
Steeple sign. Croup.
Triple
Okay.
sign. एक सेकंड.
Huh?
हाँ एक सेकंड आया.
Huh.
ये तो चार्जिंग पे लगा दूं.
Okay, okay.
बैटरी कम हो रही है.
Hmm.
Peritonsillar abscess.
Peritonsillar abscess, right soft palatal edema, left uvular deviation. Okay, right peritonsillar abscess, abscess and edema, soft palate edema, and right peritonsillar abscess, and normal left tonsil. Okay, clinical feature: fever, sore throat, daily swallowing, trismus, muffled hot potato voice, uvular deviation, and pooling of saliva. Peritonsillar abscess, muffled voice is also there. Okay, epiglottitis, enlarged epiglottis, thumbprint sign. This is the thumbprint sign. Normal epiglottis size and shape.
Second, good noise. Very similar to me. ये है
Okay, now this one.
इस आपने सही पकड़ा.
Car. Extra finding. Okay, that picture is also there. Normal epiglottis widen of the perivertebral space.
जो वाइडनिंग ऑफ पेरिवर्टिब्रल स्पेस जो आपने क्लिक किया था वही चीज थी बस. नॉइस आपका गुड यार. आपका तो आप बहुत
And
होशियार हो यार.
trachea.
सही है.
No.
पढ़ो. ये वो सवाल था कल्चर पॉजिटिव एंडोकार्डाइटिस वाला.
Okay. Staphylococcus aureus, culture positive infective endocarditis. Acha. So endocarditis, one is Staph aureus, then Baden's streptococci, Staphylococcus epidermidis. Epidermidis is also one of the cause of infective endocarditis, and then enterococci, Galolyticus, and fungi. Okay, so aureus, epidermidis, then Streptococcus galolyticus, Baden's streptococci, fungi, enterococci. Every cocci is there now. Streptococci, enterococci, variants streptococci. Okay, Staphylococcus aureus, prosthetic valve, intravascular catheter, implanted device, pacemaker or defibrillator, intravenous drug use. Then variants streptococci, gingival manipulation, respiratory tract incision or biopsy. Gingival manipulation, respiratory tract or biopsy. Staphylococcus epidermidis, prosthetic valve, intravascular catheter, implanted device. Prosthetic valve, intravascular catheter, implanted device. Okay. Then enterococci, nosocomial urinary tract infection, Galolyticus, colon carcinoma, inflammatory bowel disease. So the in urinary tract is just for enterococci. If we get any urinary tract infection, GI or GU procedure, no, then enterococci. Galolyticus, colon carcinoma, IBD, inflammatory bowel disease. Inflammatory bowel disease also cause endocarditis. It's a rare thing, no? Fungi, Candida, immunocompromised host, intravascular catheter, prolonged antibiotic therapy. Antibiotic therapy, intravascular catheter, and immunocompromised host for Candida. Okay. This patient has low-grade fever, generalized weakness, a new hollow systolic murmur, and several tender erythematous lesions affecting the fingertip, ossular node. This finding, along with a prior history of rheumatic fever, are suggestive of infective endocarditis. A variety of microorganisms can cause infective endocarditis, and certain bacteria are more frequently associated with specific clinical condition. Staphylococcal infection, most common cause of healthcare associated infective endocarditis, Staphylococcus Staph aureus. The Enterococcus species Enterococcus faecalis are another common 30% cause of nosocomial acquired endocarditis, particularly in those with associated nosocomial urinary tract infection. Given this patient history of pyelonephritis and persistent dysuria, he likely has urinary tract colonization of Enterococcus species. The bacteremia in this patient likely occurred through urinary tract manipulation from the recent cystoscopy leading to infective endocarditis. Okay, choice A. Coxiella burnetii is a rickettsial bacterium that causes Q fever via inhalation of contaminated aerosol from infected livestock or consumption of unpasteurized milk. It is seen rarely in endocarditis in immunocompromised patients with underlying valvular disease. Okay, Coxiella rickettsia. That cause Q fever, inhalation of contaminated aerosol from infected livestock or consumption of unpasteurized.
इनके ऑप्शंस को छोड़ो आप बस, ठीक है। कॉन्टेक्स्ट समझ आ गया। बाकी जो बच्चा
हाँ,
लेक्चर देखेगा खुद ही पढ़ लेगा नीचे, क्योंकि इतना ये रिपीटेड चीजें वही वही। नेक्स्ट क्वेश्चन पढ़ो, क्योंकि हमारे पास 10 मिनट है मैक्सिमम और दो क्वेश्चन है 27 28। मीजल्स वाला
measles
रबियोला।
virus, airborne respiratory particle, okay, prodorm, cough, coryza, conjunctiva, fever, coptic spot, maculopapular xanthum, cephalocoidal and centrifugal spread, usually spread palm and sole. Management, supportive care and vitamin A. Complication, pneumonia, neurologic, variable onset, encephalitis day, the acute disseminated encephalomyelitis weak, encephalitis, then disseminated encephalomyelitis weak, and subacute sclerosing panencephalitis years. Prevention live attenuated vaccine. Okay, the unvaccinated child has fever and a diffuse maculopapular rash following a prodrome of cough, conjunctiva, and coryza, finding consistent with measles, rubiola. The rash characteristically began on the face and spread cephalocaudally, often sparing the palm and sole, as in this patient. In this case, the disease course has been complicated by pneumonia, which is clinically evident given the patient shortness of breath, tachypnea, crackle. Pneumonia may be due to the measles virus itself or secondary bacterial infection. Acha. Management of the measles is primarily supportive, fluid, antipyretic, and in most patients, symptom resolve within 1 to 2 weeks. However, increasing morbidity, prolonged illness, hospitalization, and mortality are associated with vitamin A deficiency, particularly in young children. Because measles can cause precipitate vitamin A deficiency, likely due to increased use during the acute illness. Vitamin A administration is recommended for children with measles, especially those with severe disease, as in this child who is hospitalized with pneumonia. Vitamin A likely reduce complications through the promotion of antibody producing cell and regeneration of epithelial cell in the gut and lung and retina. Okay, then should I read the option? I think no, na.
पढ़ लो
It's
पढ़ लो,
obvious.
इसके पढ़ लो
Okay.
भले।
Okay. Acha. Patient treated for pulmonary tuberculosis.
नहीं, वेट वेट, बस सही है ये। हमें भी नहीं उसके B6 उसमें यूज करते हैं, B12 हमें पता है नॉर्मली किसलिए यूज होते हैं, E एंड K भी पता है। ठीक है, कफ कोरेजा कंजक्टिवाइटिस हमने पढ़ लिया, आगे चलो लास्ट सवाल
हाँ,
करो। ये सवाल ये था हमारा
हाँ,
HSV वाला, वायरल एनकेफेलाइटिस वाला, ये वायरल एसोफेजाइटिस वाला, सॉरी। पढ़ो।
अच्छा। तो हाँ, esophagitis in patient with HIV. Candida albicans, oral thrush usually present, white plaque throughout the esophagus, and biopsy pseudohyphae. Biopsy pseudohyphae. Okay. Herpes simplex, orolabial lesion simplex volcano lesion. Biopsy. Biopsy nucleated giant cell. Okay. Volcano-like cytomegalolinear and esophageal white plaque throughout the esophagus, and throughout the esophagus there is a white plaque, and biopsy pseudohyphae. Cytomegalo biopsy, intranuclear or intracytoplasmic inclusion. Intranuclear or intracytoplasmic. Infectious. Okay, infectious esophagitis is common in patients with advanced HIV, especially with CD4 count less than 100. The most common cause of esophagitis in patients with HIV is Candida albicans, more than 60% case. However, viral esophagitis is more likely than Candida esophagitis in patients who have severe odynophagia, pain with swallowing as the predominant symptom. No dysphagia, difficulty swallowing. Okay, pain with swallowing but no dysphagia and no thrush. The most commonly implicated virus in viral esophagitis include herpes simplex and cytomegalovirus. The diagnosis is generally made on the upper gastrointestinal endoscopy biopsy. HSV usually cause circular and ovoid vesicular and ulcerated lesion. Cytomegalovirus infection typically cause large linear distal esophageal ulcer. Histopathology and culture confirm the diagnosis. Okay. Other option, several features make viral esophagitis more likely than candida esophagitis in this patient. The large majority of the patient with candida esophagitis have oral thrush, although lack of thrush does not exclude the diagnosis. Okay, it's an important info now. Here, the oral thrush was not present, but it doesn't mean that we can exclude the candida. Most have prominent dysphagia rather than odynophagia. So dysphagia, one of this is oral thrush, and another thing is dysphagia. If present with odynophagia in general, mild to moderate. Okay. Symptomatic patient, usually with visible thrush, can be treated empirically for candida esophagitis with fluconazole. Endoscopy is usually performed in those with failing treatment. Okay. First we give fluconazole, and if failed, then we perform the endoscopy.
एक डिफरेंशिएटिंग फैक्टर था आपका थ्रश, अगर है तो कैंडिडा, नहीं है तो एचएसवी. दूसरा डिफरेंशिएटिंग फैक्टर है ओडाइनोफेजिया, अगर माइल्डर है तो कैंडिडा, अगर बहुत ज्यादा है सिवियर है तो एसोफेजिया, अपना हर्पीस सिम्प्लेक्स यानी वायरल एसोफेजाइटिस. ठीक है, अगर आपका जो डिस्फेजिया है वो है प्रेजेंट है तो दैट मींस कैंडिडा. अगर डिस्फेजिया इतना खास नहीं है, देखो डिस्फेजिया का इतना मेंशन हो ना हो, लेकिन ओडाइनोफेजिया का मेंशन है, तो आपका होता है हर्पीस सिम्प्लेक्स वायरस. आगे बढ़ो. हर्पीस इज ऑलवेज पेनफुल. उसका शंकर हो, उसका शंकर नहीं, उसका लीजन हो, वेजाइकल हो, स्किन पे, जेनिटल्स पे, गले में, हर जगह पे गुनाहों का सजा जो है दर्द है. आगे बढ़ो.
Okay. And another is cytomegalo. Herpes simplex and cytomegalo, both are painful. Odynophagia. Okay. Eosinophilic esophagitis can be seen in patients who have atopic condition, asthma, seasonal allergy. However, it is uncommon disorder and manifestation typically include dysphagia, heartburn, refractory acid reflux. Odynophagia, especially severe, is rare. In addition, symptom usually develop chronically rather than acutely, as seen in this patient. Okay. Gastroesophageal reflux disease typically present heartburn, chest pain, dysphagia. However, odynophagia, especially severe, is not commonly associated with GERD and warrant evaluation for other possible cause. Okay. Then choice D, medication related chemical esophagitis. Pill esophagitis can cause acute odynophagia due to direct effect of a medication on a esophageal mucosa. Common offending medication include potassium chloride, tetracycline, bisphosphonate, and non-steroidal anti-inflammatory. So other large or multi-pill medication can cause dysphagia. They less commonly cause true pill esophagitis. Okay. Educational objective, infectious esophagitis is a common complication seen in patients with advanced HIV disease and with oral thrush. Most likely have candida esophagitis with viral cause. Herpes simplex cytomegalovirus being more likely in the setting of severe odynophagia without dysphagia or thrush. Achha, the diagnosis is confirmed with upper gastrointestinal endoscopy. Okay. Next question, Orithina.
नेक्स्ट क्वेश्चन हमने हो गया, ये हमने किया था, दिखाता हूँ. इसकी एक्सप्लेनेशन हमने वहां पढ़ ली थी, इसकी और इसकी दोनों.
ओके.
के बाकी 31st से लेकर हम लोग कल करेंगे. आज के लिए अल्लाह हाफिज. आपको भी तो देखते हैं, लोगों को भी अल्लाह हाफिज.